So, very good evening and a warm welcome to everyone. At the outset, before I begin, I'd like to take this opportunity to congratulate Dr. Sudeep sir and Dr. Shona ma'am for putting together this wonderful academic extravaganza year after year, and also thank them for the opportunity. So, I'm going to be discussing a couple of key abstracts in the HER2 positive breast cancer setting. So, the first of which is the phase 2 study, the ATTEMPT study, which looked at adjuvant TDM1 versus the APT regimen in early stage HER2 positive breast cancer patients. So we all know that based on the app study by Sarah Tolani et al., that the app regimen has become the standard of care as far as patients with early stage HER2 positive breast cancer with tumors less than 3 centimeters is concerned. And TDM1 has become the standard of care for patients with any sort of residual disease after neoadjuvant therapy based on the CAT3 study. So attempt basically looked at attempting to establish whether adjuvant TDM1 would be better off than the apt regimen in early stage HER2 positive breast cancer. So this was the randomization in patients with early stage HER2 positive breast cancer, TDM1 versus the apt regimen with continued with trastuzumab up to 1 year, and co-primary endpoints of 3-year DFS, and more importantly, comparison of clinically relevant toxicities. So as far as the baseline characteristics were concerned, they were pretty evenly matched. When if you look at the number of lesions, patients with less than 1 centimeter tumors, around 43%, and between 1 to 2 centimeters, around 57%. And they were evenly matched as far as the hormone receptor status as well. So let's look at the DFS in the entire intention to treat population. Well, if you look at it in comparison with the APT regimen, if you look at the 3-year DFS, clearly the delta was lesser by around 5%, 5 to 6% with the attempt regimen, which was just adjuvant TDM1 alone, which is why probably APT still remains the standard of care in that subset. And when you look at the clinical relevant toxicities as well, attempt did not meet the co-primary endpoint which they had set out to meet of at least 40% relative reduction in toxicity. That was not met. And in fact, the treatment discontinuation rates were much higher in the TDM1 arm, 17% versus 66%. In the context of a phase 2 study, I think that's pretty significant for me. And if you look at the reasons for TDM1 discontinuation, I think for toxicity led the chart with 17%. And for toxicity, protocol mandated around 9%, but still overall toxicity 17%, like I said earlier, in the setting of a phase 2 study, definitely not worth changing practice. So what are the conclusions from that study? Well, very few recurrences. Well, the DFS at 3 years was only 97%. That's how the investigators look at it. But, well, like I had said earlier, the co-primary endpoints of lesser toxicities was not met. And again, I don't think it's an alternative to the APT regimen in stage 1. HER2 positive breast cancer, especially in patients who have concerns about toxicities. Probably shorter duration of TDM1 could be evaluated in future studies, but definitely not worth changing practice in my view. And the points to ponder are, as far as phase 2 studies go, the APT regimen would actually be a much better choice in clinical practice. And this study is definitely a negative study. Primary endpoint was not met. And not only that, the phase 3 Caitlin study, which looked at TDM1 after anthracyclines in the adjuvant setting, was a negative study. So you have a negative phase 3 study as well, which is yet another blow to TDM1 in that setting. And we know that TDM1 is already losing ground to trastuzumab deruxtecan based on the Destiny Breast 04 study that was presented at ESMO 21 as well. So definitely not at the cost of higher toxicity, and most definitely not worth changing practice at all in my view. So let's move on to the next study, which is the Iron Passion 50 study, which looked at addition of immune checkpoint inhibitor atezolizumab to a dual HER2 blockade plus chemotherapy in high-risk HER2 positive early breast cancer. So we all know that dual HER2 blockade is the standard of care for anybody with high-risk HER2 positive early breast cancer, and TDM1 is the standard of care in the adjuvant setting for anybody with residual disease. So the rationale for combining atezolizumab with dual HER2 blockade is that, in short, you're potentially making the tumor microenvironment much more conducive to immune checkpoint inhibitors. You're making a cold tumor hot and making it more conducive to immune checkpoint inhibitors. So let's look at the study design. This, again, the randomization was between anthracycline plus taxane along with dual HER2 blockade plus or minus atezolizumab, and the median follow-up of around 3 years. So co-primary endpoints were PAT-CR in the intention to treat population and in the PD-L1 positive subset. The baseline characteristics were pretty evenly matched, with around 52% of the patients being PD-L1 negative and around 48% being PD-L1 positive. So if you look at the co-primary endpoints, even the entire intention to treat population, the PAT-CR rates were absolutely similar. So nothing to choose from at all. And again, the PD-L1 positive subset, even though it was numerically significant at around 8% absolute difference, the delta would be around 8% absolute significance. But that was not statistically significant. Look at the p-value, definitely not statistically significant. The secondary endpoint of PATSIA and the PD-L1 negative subset, well, again, despite the absolute improvement in delta of around 7%, this was also not statistically significant. And if you look at it across all subgroups as well, clearly, as you can see here, nothing favored atezolizumab. And that's the reason as to why this is a negative study. And the secondary endpoint of EFS, look at the curves, they're absolutely hugging each other. Albeit, yes, this was definitely not powered enough adequately to answer the question of EFS, but the median follow-up of around 15 months, the EFS data is definitely immature. Overall safety, well, the key thing here was the grade 5 adverse events, higher in the atezolizumab arm, and one of the reasons why the IMDC actually recommended stopping the study because of futility, and not just futility, but also the increased toxicity and deaths as well. So to summarize again, atezolizumab did not increase the FAT-CR rates. The safety profile was worse off. You had 5 fatal adverse events in the atezolizumab arm. And so dual HER2 blockade plus chemotherapy still remains the standard of care for HER2 positive early breast cancer. And you need a lot of future studies looking at the role of immune checkpoint inhibitors in HER2 positive early breast cancer and metastatic breast cancer. And probably it would be worthwhile looking at EFS or DFS as a primary endpoint rather than just PAT-CR, because that will allow for the immune-mediated anti-tumor effects to take place. And we know immune checkpoint inhibitors take a longer time to bring about its maximum depth of response. So I think that really would make sense. And this is what I alluded to earlier as to why the rationale behind why you'd want to look at adding immune checkpoint inhibitors. And that's because of the role it has to play in modifying the tumor microenvironment, making it more conducive to the immunotherapy. And we've had data in the HER2 positive MBC on the role of immune checkpoint inhibitors, out of which KATE was the only phase 2 data. And again, you can see an improvement in the overall response rate and the PFS as well with the addition of atezolizumab to TDM1 in the metastatic setting. So why are we seeing such different results in the metastatic setting as well as in the early setting? So one reason is that definitely, yes, the immune response will definitely be different in both the settings. In the advanced setting, we know that the tumor burden is much higher thereby, and also we know that on recurrence, the tumor has actually learned about immune evasion as well. There are more mechanisms of resistance, and the host is often immunosuppressed as well. Whereas in the early setting, the disease is confined to the breast, and when we know that the malignancy is going to be completely removed, thereby there's less exhaustion of T cells as well, and the host is not as immunosuppressed. So I think those are the key differences as to why we're seeing the difference in the results as well. And do we have the perfect biomarker yet? I think that will be debated on for ages to come. But yeah, these are all the biomarkers that have been looked at: MSI, TMB, the TILs, and PDL1. But we still don't have that single perfect biomarker. So which assay, which antibody, which cells, which scoring, and which cutoff? Well, that still remains an area of active debate. And again, clearly the grade 5 adverse events were much higher in the atezolizumab arm, which led to the IMDC actually pulling the plug on this trial, and hence definitely not practice changing. But is that the end of IO in HER2 positive breast cancer patients? I don't think so, because there are a lot of ongoing studies looking at the role of immune checkpoint inhibitors even in early stage HER2 positive breast cancer. So ideally, if you were to look at designing a trial, you could look at doing neoadjuvant immune checkpoint inhibitors and then classifying them as responders versus non-responders, meaning people who have achieved a PAT-CR versus residual disease. And then the randomization could be between addition of immune checkpoint inhibitors versus any other new strategy that actually comes up, albeit different other mechanisms of resistance as well. And ideally, the study should be powered to detect any difference in survival. And the chemotherapy backbone of choice still remains an area of active debate as well. So the points to ponder before I end up is that how do we look at identifying or better selecting these patients? Do we have better predictive biomarkers? And we've learned our lessons from immunotherapy in the triple negative breast cancer setting as well, where the plug has been pulled on atezolizumab based on the Iron Passion 131 data. So, and is PAT-CR the best biomarker yet? Well, it's not definitely the most appropriate endpoint, especially if you're looking at immune checkpoint inhibitors. So EFS or DFS would actually be a much better endpoint rather than just PAT-CR, and the trial should be powered adequately. So my conclusions, obviously, the Iron Passion 50 did not meet its primary endpoint, and that's the reason as to why dual HER2 blockade plus chemo still remains the standard of care. And we still are looking out for the predictive biomarkers or the ideal biomarker. And the clinical trials in future at least should be looked at powering, they should be adequately powered to look at survival endpoints or EFS as their primary endpoint, which will actually allow for a better measure of immunotherapy's effects over time. And we need to be absolutely vigilant with add-on designs or adaptive randomization and the multi-arm, multi-stage, as we have seen with the Stampede study. So I think with that, I'll conclude and say thank you all for your patience.